Hello everybody, and welcome to the InTouch Health webinar series. This is Scott Young, and I'm going to be your host for today's webinar. Today we're going to be featuring Kelton Tembe of InTouch Health and Dr. Wu of the University of Texas Health presenting on teleneurology. We're going to begin the webinar shortly, but first, a few notices. You've all been auto-muted. If not, please make sure to mute yourself. At the bottom of your audience console are multiple application widgets you can use. If you have any technical difficulty, please click on the Help widget. It has a question mark icon and covers common technical issues. You can expand the slide area by clicking on the Maximize icon on the top right of the slide area or by dragging the bottom right corner of the slide area. During the webinar, you'll be able to enter questions in the Q&A widget located on your audience console. Questions will be answered at the conclusion of the presentation, so please feel free to ask your questions at any point throughout the webinar. If a fuller answer is needed or we run out of time, questions will be answered later via email. This webinar will be recorded, and a copy of the recording will be available on our website, and a link will be posted at the end of this webinar. This webinar presentation should not exceed 60 minutes, including time for Q&A. And now I'd like to turn it over to Kelton, who will introduce Dr. Wu.
Dr. Teddy Wu went to medical school at the University of Maryland School of Medicine and completed his neurology residency at the Barrow Neurological Institute at St. Joseph's Hospital in Phoenix, Arizona. He then went on to the University of Texas Health Science Center in Houston to complete a 2-year neurovascular fellowship in 2011 and has been the director of teleneurology since that time. He has performed thousands of acute teleneurology consultations and assisted in over 700 TPA administrations via telemedicine. His research interests focus on expansion of access to stroke expertise through the use of technology. Using InTouch Analytics, we know Dr. Wu was the #1 telestroke user in 2017, and his program continues to be a leader in teleneurology. Without further ado, here's Dr. Wu.
All right. Thank you, Kelton, for that kind introduction, and thank you for everyone that's participating on the call, listening to me talk for today. Today, I'm going to talk a lot about our program and what we've identified as things that really led us to, in my opinion, to be a very successful teleneurology program, and what we've learned as we've built our program and as we've grown. So the objectives for today is that I'm going to give a brief overview of our program and how our network is laid out, talk about the importance of defining the goals of the program and how that sometimes needs to be changed and updated, and the importance of training, which is not just training your spoke sites, but also training your hub and your physicians before you launch, and also continue education after you launch a program. Identify ways to improve quality, efficiency, importance of tracking of the data, and lastly, we talk about sharing success of your network. I dive into it. Brief things of why is teleneurology even needed, or telestroke is needed. I talk to a lot of medical students and residents, and this is thing I always show them is that it's important to understand kind of what the problem is. We know that stroke continues to drop on the list as far as leading cause of death throughout the United States. However, it's still the leading cause of long-term disability in the United States. We all know that stroke is a treatable disease, and although we've made tremendous improvements over the last decades, we still know that we only have IV-TPA as the only proven medical therapy. It has a very, very narrow time window, and there are risks specific with hemorrhagic conversion or bleeding risk, but it is a very, very powerful medicine. We know that if you give it to 8 patients, 1 of them become near normal, and then 1 in 3 is going to improve. So it's a very, very powerful medicine, but there are risks associated with that. Luckily for us in the stroke field, there's been a tremendous movement in the amount of things that we can do for our patients, specifically with arterial thrombectomy, when we're able to, in certain patients, use a catheter, go up to the brain to take the clot out via endovascular approach. And again, just like IV-TPA, both treatments really need to be delivered fast in order to be effective. And we know that although we've made dramatic improvements, that IVTPA is still underutilized, and we need to expand access to intraarterial thrombectomy, and that's why telestroke and teleneurology is still quite important. So and again, going forward, we know that there's about 800,000 strokes a year, and as our population continues to age, the incidence is likely to double by 2050. Fortunately, on the other end, is that there's a huge shortage of neurologists. It's been estimated by 2025 we're at a 19% deficit as far as the amount of neurologists we actually need per population, and that's for general neurologists, and that doesn't account for the fact of how many stroke-trained vascular neurologists are out in the community. We all have experienced this, is that a number of neurologists are no longer taking call. There is decreased amount of time they want to take hospital call, and a lot of them aren't even providing inpatient consultations because of the burden that financially on their part for the amount of care they can do for their outpatient practices. That all leads to lack of access of acute expertise. A lot of our subspecialty care physicians, whether that be stroke neurologist or pediatric cardiology, a lot of them are mainly based in urban areas with a lot of population. So a lot of our facilities out in the smaller community areas really don't have access to a lot of these higher, more experienced practitioners. There still is a lot of uncertainty with ER physicians, not all, but some, about administering IVTPA without the guidance from neurologists, and that creates a huge problem, obviously, for our patients. And we know that there's still a huge disparity for acute stroke care in rural populations when studies have shown that patients that are arriving in a rural area, they're 10 times less likely to receive IVTPA for their acute stroke that they're having compared to our urban hospitals. And then for Texas, where we practice, it is one of the largest, has one of the largest rural populations. So we know that teleneurology is important, telestroke is important. Facilities want it, physicians want to do it, but how do we do it? How do we do it right? How do we do it efficiently? How do we provide high quality care? This is kind of what I'm going to focus the rest of the talk about. So why do we get into the game at UTHealth, Neurology? So I came to UT Houston for my 2-year fellowship in 2009, and we had already been doing teleneurology and telestroke in 3 hospitals before that. For those that aren't aware of how the Texas Medical Center was laid out, we actually had 3 other, at that time there were not comprehensive stroke centers, that designation was in play, but 3 large stroke centers in addition to the one that we were practiced within about a 2-mile radius. What we had noticed, because we did a lot of research, is that we were not getting as many research patients or research appropriate patients to our facility because of rampant growth of all the other hospitals that are around. So it was at that point in which we really felt that we need to improve our outreach and solidify our relationships with our existing referral hospitals so that we can increase access not only to our main campus hospital down the TMC, but right now we have also 3 other comprehensive stroke centers within the Memorial Hermann Hospital System, which is our teaching affiliated hospital to UT Houston. Obviously, we wanted to increase the overall neurological care in the region. And more importantly, and this is what a lot of our facilities have asking for, is, we really don't want to transfer patients unless they absolutely wanted to encourage hospitals to not keep their own patients when needed. The families actually want to stay in the community as well. Oftentimes our stroke patients are much older. They don't want to have to travel to visit their loved one and drive all the way, 2-3 hours to see their family members that may not even need to be transferred in the first place. Built into our program goals was heavily focused on education. We wanted to educate our surrounding hospitals about the newer treatment algorithms and be able to provide them with education of how to or why we need to transfer certain patients, and also offer our patients participation in research protocols that otherwise weren't available in either. At the end of the day, we really felt that we want to offer some benefits to the patients, the family, and the community hospitals, and it wasn't just solely just to have access to patients and bring everybody down to our campuses. Our program model, and that kind of morphed throughout as we were able to engage in our sites. We were lucky enough to have had philanthropic donations to start our teleneurology telestroke program. And our initial model was that we got into the cars, we drove to local hospitals in our region, and what we offered was basically that we will provide 24/7 acute telestroke coverage for free. We would give you the equipment, we will provide the consultative services for free for 2 years. And our hopes are that after 2 years and understanding the tremendous value that they would have access to, that it would then transform into a fee-based type of model. So our initial program role was to provide 24/7 acute telestroke coverage. As our program continually to grow, it expanded to not only acute telestroke, but more acute teleneurology. Oftentimes, facilities that needed somebody to talk to about, hey, who do we call for those patients who were coming in with acute status epilepticus or acute paraparesis or acute ulnar mental status change, because they didn't have that neurological coverage to begin with. And from our standpoint, if we said, hey, we're only going to provide telestroke coverage and call somebody else for that, that wasn't really beneficial to our spoke hospital. Over the last probably 4 or 5 years, we've also transitioned into providing some routine teleneurology consultations in some of our facilities that lack neurological coverage from an. Now, as it currently stands, I say 3 hubs. We actually have a 4-hub and a 17-spoke model. We have a very mixed network that provides a lot of complication into how we provide care. However, it is the way our network is set up. We have 9 hospitals in our 17 spoke system within the Moore-Herman system that operates out of 1 EMR and 1 PAC system, so that makes it much, much easier. Then we have 8 of the other 17 hospitals that sit outside of the Moore-Herman system with their own individual EMR access and PAC systems. So that makes it quite difficult. Just to give you some understanding of how much volume our network provides, I just pulled the data from last year, 2018. We are providing about 10,000 consults a year. That continues to rise as we continue to grow. We've helped administer TPA about 464 times last year. We've only transferred 676 patients out of those 10,000. Now, that 10,000 is a mixed number. About half of that were routine consultations. So, the other 5,000 that were acute teleneurology or telestroke, about a couple thousand was also just things we dealt over by the phone. So we're really seeing about 3,500 to 4,000 acute telestroke teleneurology consultations. The rest were phone or routine consultations that we were seeing as we were rounding in their hospitals. So the most important thing, and this is something that we've also learned and built into when we approach new sites, is the importance of defining the roles and the goals of your program. This is quite important. As the program director of teleneurology and telemedicine from the FAR Department of Neurology, I may have one view of what we're trying to do. However, the hub hospitals have their point of view. Do they want more patients for intraarterial thrombectomy? Do they want some arachnoid hemorrhages? How do they want to refer patients in the network? The different program managers may have different views on things. Who's going to be doing the consults and what type of patients do we want to see? The physicians also have a huge play of, what the goal and the role is. Some of our physicians initially were not too excited about providing routine general neurology consultations if they were stroke trained. They felt like that was out of the scope of what they were hired to do. So that's quite important to have an understanding of what we're trying to do. And obviously from a departmental or division standpoint, it's important to understand what this program brings to the overall department. For us, the School of Medicine here at McGovern. I think this is probably one of the most important things that people struggle with, and you'll see that there are various networks that are out in the market that some provide all teleneurology and some just provide telestroke. So it's important that you see some of these networks that have maybe smaller volumes and maybe that they're just providing telestroke and not teleneurology. But I would say that the market is definitely pushing towards more and more services because when hospitals lack telestroke coverage, that really means they're lacking neurology coverage in general. One of the most important things that we really outlined when we set up our program is that we identified for us the importance of having the right physicians to provide the consultative service. For us, we chose the stroke attendings that were fellowship trained, have a lot of experience given IBTPA for the mere fact that most of our calls are for stroke. Most of acute neurology is for stroke, and that we're more apt into dealing with these patients. However, there are networks out there that use general neurologists, and I think that's perfectly fine if they're more than comfortable in doing that. You want trainees to be involved. You want your fellows to be involved if you have fellows in your program. Our fellows that are training in our stroke program here do a rotation with a high-level supervision. Some places don't allow that, and some places do. When we were creating our network in the beginning, when we were having issues with coverage, we thought about offering our pool of physicians to include a community neurologist. And there's pros and cons to that. But it's important to identify, who you really want to be providing the consultative services, because when you go out and sell your service, people do want to know, who's going to get on the camera? Is it going to be a resident? Going to be a fellow, or do I get, attending that's been experienced in what they're doing? Also, the location of where you provide the consultative services is quite important. That may depend on the infrastructure of the local hospital. Do they have good enough Wi-Fi throughout the hospital? Something most places do. So do you only provide consultations in the emergency room, or does that include the medical floors? We all know that stroke not only happens in the ER, but that also happens on the floor. So do you want to cover those or not? And how does that impact training? How does that impact the technology you choose? Will you provide follow-up consultative services? We get asked this question all the time when we approach new hospitals. What if a patient gets admitted and gets worse? Who do I call? What if they have hemorrhage after TPA administration? Who do I call? How long will you follow up that patient for? Are you going to get back on the camera if necessary? Will you facilitate discussing the case with our hospitalists that may admit these patients after you've seen them in the ER? For what we do, we are available to follow up on all of our patients via phone or our telemedicine platform if necessary, until a neurologist takes over those cases or physicians have seen them. But we were always available to follow up on all. One of the most important things, and this depends on how your network is set up, is how will you facilitate the transfer process? If you have a hub-and-spoke network and you are able to take in your own patients to the local facility, oftentimes our spoke sites want that process to be much smoother. We can facilitate that will be important. There are networks out there that are more of a doc-in-a-box type of network in which physicians that are providing the consultations really don't have a local hospital to transfer to, and may be a little bit more difficult for them to facilitate in that and then morphs into, what network model do you use? Do you use local physicians that you have access to? Or are you using physicians outside the network? Are you using physicians that are located locally or not? That's probably very, very important. We've chose to keep our physician pool very, very small so we understand the local politics. We are local to all of our hospitals. So often travel and they see us all the time and they get to know us pretty well. The role of teleneurology of what we do now, again, we provide acute neurological consultative services 24/7 in the hospital and anywhere. We can either supplement your current neurological coverage so that some hospitals in which they have neurohospitalists during the daytime, we provide coverage after hours. Some hospitals were 24/7 for everything when they don't have any neurological coverage. Potential cases that we deal with are patients that may be eligible for IVTPA or thrombectomy if they've had a hemorrhage or status epilepticus. And because we have our own comprehensive stroke center hubs, and we have 4 within our system, we can expedite transfer with pre-acceptance. Oftentimes when I'm seeing patients on the camera and I can see that they have a large vessel occlusion on a CTA or even just a CAT scan, while I'm arranging for IVTPA administration, discussing that, I'm also on the phone with our transfer center to let them know that this hospital is going to be calling about this patient. Please send a helicopter service and pre-accept this patient so we can get that transfer process on their way. And that makes that transfer process so much easier for the referring hospital so that they're not on the phone and then regurgitating the whole area of why they need to transfer that patient. And then from the telemedicine side, after I see the patient, I'm contacting our intraarterial thrombectomy endovascular team and also our stroke fellows to let them know what the case is about. I send them our notes so they understand kind of what we're dealing with when the patient arrives. At 3 of our hospitals, we also provide routine and non-urgent consultations and follow-up 7 days a week, 8 to 5, where we're contracted to do that. Obviously, and what the facilities locally can handle, do that through the ER, transfer out, and patients that we're able to deal with. Again, this is kind of me getting on a soapbox, but, understanding the telestroke models that are out there, you have a third party, more of a doc-in-a-box type of network in which you have a third-party consultative services that's kind of set out there, maybe throughout the nation that don't necessarily have ties to any local hospital, which is probably one of the bigger models nationally when you have more commercial providers do that. I preferably don't recommend models like that just because it's the physicians and of the people that may be providing the services, they have less incentive to really try to understand the local politics and how to get things done. So I would say that, my recommendation is that if possible, the hub and spoke model and having your physicians sit in the hub and understanding, what you can and cannot do and your local resources is probably a little bit more preferential, in my opinion. You're able to visit your spokes yourself. You know your endovascular team, you know your neurosurgeon. That just makes things a lot easier from a communication standpoint, a lot more efficient. So, again, I would say that if you're starting a network, right now, if you're able to do it, I would think that the hub and spoke. Importance of training. This is something we've learned as we started to grow our program. Initially, we provided training, it could be a few hours to a few people that actually show up to the meeting. Now it's morphed to day-long and occasionally 2-day-long training sessions at all of our spoke sites. At pre-launch, we do mock emergency stroke codes. We bring people from different shifts throughout the ER. We include nurses on the floors. We include techs, physicians, unit secretaries. We bring them all in, and we run sessions all day long to capture everybody at various shifts. We run emergency stroke codes. We run mock inpatient stroke codes until everybody understands what teleneurology and telestroke is about and understanding the role and the expectations of what the physician's going to do on the camera when they get on, and also the expectations of the nurses and the techs, and even the unit secretaries of how they contact us. And as long as everybody understands before everything even starts and becomes live, I think it's quite important for everybody to meet face-to-face and understand kind of pre-launch what we're trying to get in, what services we'll be delivering, what the expectations are. And once we hit our stride and the spokes are live, we also provide ongoing in-servicing. I actually get on the camera and get on our endpoints and go over IVTPA time metrics, why those things are important. Review our thrombectomy protocols, the importance of why we need to be fast about getting CT angiograms if necessary. Review the recognitions of stroke signs and symptoms. Educate on various screening tools such as our large vessel screening tool. Can identify these patients earlier, and also review the transfer process. The nurses locally, even some of the physicians sometimes don't understand how the transfer process actually works. One of the biggest issues that we've had with delay in transfers was that the local hospitals weren't calling our transfer center, thinking that the process would take place even when we pre-accept. But as most people know, we cannot pre-accept the patient and ask the patient to come to us. They actually have to initiate that transfer. There'll be some violations in how we are transferring patients, that the local facilities actually have to initiate and request the transfer. So that's very, very important, is to continue to train and make yourself available to do that for your spokes. It's quite important. Vice versa, it's also excruciating important. I need to highlight the importance of training at the hub. We do a lot of physicians training. We onboard our stroke fellows when they're obviously brand new to this technology and they don't understand some of the limitations of what teleneurology and teleneurology brings. So we take a lot of time to train our stroke fellows and play with the technology, see us do consults, and we let them observe us and we observe them only until we feel like they're competent and do the consults on their with our supervision afterwards. A lot of that with our new stroke faculty as well. Important to understand and make everybody review how do we access different EMRs. As I was talking about before, 9 out of the hospitals that we cover is within Memorial Hermann, so it's very, very easy. There's one place you need to log in, one EMR you need to learn, and one PAC system that you need to learn. So for those 8 other hospitals that we cover, we currently use Clinical Apps, which is an InTouch product that allows us to document and have access to PACS integration as well. So, having our stroke fellows and stroke faculty understand how to maneuver within that platform is quite important as well. Also review downtime protocols in case technology shuts down. What do we do? If you have your internet going out, what do you do at that point as well? We also review and update site capabilities as either hospitals gain more capabilities, such as the ability to use CT angiograms, or they just acquire rapid perfusion. That's important. Update on transfer patterns. Right now we have a regional transfer pattern, which we really referring hospitals and their patients to the closest comprehensive stroke center, as opposed to just all coming down to the Texas Medical Center, which may not be geographically better for a patient if it's a little bit farther travel. Call center training. Again, it's important for them to understand why it's important for them to relay those calls to our physicians fast. Also training our spokes of how to access our call center, what information they need to be giving them so that when we get those calls, we can see our consults as fast and as efficient as possible. Implementing backup plans, again, downtime. We learned a lot about that during the hurricane season when we had a lot of issues with that when power went out, and how we're going to deal with those issues. So in switching gears, I would say the things that we really felt, or I really felt as the telemedicine director of how we can really improve and maintain quality and efficiency. And I would say that it starts with building an experienced and dedicated team. I would say that although not many networks and programs we agree, I've decided to really keep our team as slim as possible. We right now have 4 full-time telemedicine vascular trained neurologists. So all of us have gone through formal stroke fellowship training. We've all done telemedicine during fellowship and have continued to chosen to do telemedicine as our full-time jobs. We have an experienced program manager that understands how to launch programs and how to interact with our spokes, and has been in the teleneurology and telehealth space for a long time. In addition to our full full-time stroke neurology trained neurologist, we also have other stroke attendings that reside within the Department of Neurology, but in the stroke division, that provide additional on-call help as well. About 4 other physicians that provide coverage in addition. In my opinion, I think having a smaller core team allows you to be more nimble for change and to disseminate new information. But as your network continues to grow, if your network is really, really large, it may not be feasible for you to have a small team. However, if you have 30, 40 doctors in your call pool, but if they only take 1 call every few months, they're not going to understand how fast things can change and how things are different. They're not going to be as efficient as opposed to somebody that was doing this basically every day. I think things to improve care as well is to streamline and simplify protocols and procedures. We chose InTouch Health because the technology is so simple to use. Always on, the nurses don't have to do anything. As long as they position it to the right place, it's really hands-off. And it's as if I was in that room physically, and all I have to do is instruct the nurses to help me examine the patient. We really want to minimize any changes to the workflow for the on-the-ground personnel. Having the nurses just do the normal jobs with the teleneurology platform there is really what we're really asking for. We don't want them to change what they do completely just for us to deliver telestroke services. Because the more complicated it gets, the less apt they're going to be able to adopt it and the less efficient it's going to be. Also, communicating back to the referring physician is quite important for us and for the care of the patients. A lot of our referring physicians love when we get on the phone and talk to them or bring them into the room, have the discussion, or examine patients together. That only solidifies that relationship you have with the local sites and allows them to ask questions and understand your thought process in delivering that care, and they really appreciate that. Provide very prompt feedback. Anytime we have any issues with the case that we're seeing, we're oftentimes on the phone right afterwards to talk to our local sites about how we can improve, whether that be issues on our end, from the physician side, from the hub side, or vice versa. For us, and I would say probably one of the biggest reasons why I think we were able to maintain our quality is that we had a very strategic and calculated growth, or we grew very strategically is what I meant. We've had many hospitals that wanted more and more services that were being offered, or they wanted more services from us. We just didn't have enough staff to do that. I would say probably some of the downfall that I see throughout in the telestroke, teleneurology spaces, that the networks grew too fast and you don't have enough physicians to offer that care. Oftentimes that leads to a lot of our patients not being taken care of on a timely basis, or you're not offering good consultative services. So I think, to really maintain that quality, you have to grow strategically, be well-staffed, don't cut corners on training, and that's what we've decided to do, is not to offer service that we don't feel like we can provide at a high quality. Again, continue to reevaluate the goals of network. That continues to change for us. We meet together from the physician side and our program manager, every couple of weeks to talk about how we can continue to grow or improve the things that we're doing. One of the things that we're going to focus on is not only deal with the inpatient aspect of teleneurology, whether that's in the ER or the routine consultative services, but how do we bring that to the outpatient side? That's one of the things that we're going to work on, one of our goals this year. And again, develop a relationship with your technology vendor is quite important. We know our tech support, Sean Cubido, has been extremely awesome for us, but understanding and then talking to them about the local problems, and how to solve those issues. Oftentimes, our local spokes may have new upgrades or updates to their system that may affect the teleneurology service, and having your tech vendor understand how to get hold of those people locally to fix those problems quickly is very, very important, because the last thing you want to do is find out there's issues when there's a stroke patient that needs to be seen and you can't see them. So understanding what your technology vendor can do for you, what type of services they can provide, is quite important for you to maintain a high quality of service. So I talked about this. One of the reasons why we chose InTouch is that it's so easy to use. It's very mobile. When we use it to round, our nurse practitioner just rolls it from room to room, and the battery holds, and it allows us to run rounds very, very efficiently. It is continuously being monitored for connectivity. So when it's down, I know it's down. There's patients that need to be seen is when I realize something is off. It is technology. Things break. So oftentimes, if there are issues with the device because the battery is not doing well, at least I'm being made aware of those issues if it's down, and because it's continuously being monitored. Having said that, it is very, very reliable. We've had very little issues with reliability of technology. And again, I do want to highlight the excellent service team that we work with at InTouch. They also do a lot of PACS integration if needed through their platform class. That's been really useful to us in the hospitals that are outside of Memorial. Data tracking. We provide annual consultative data to all of our spoke sites, what type of consults they do, how many we've done. We review quality metrics of door to TPA times, transfer times, door to them paging us, how much time does it take us to respond, to get on the camera. We track all that. We're lucky enough to have state funding through the registry called Lester, through the Lone Star Stroke Consortium, that allow us and given us funds to have staff to populate our registry that captures all this information, including long-term outcomes. With that information, we provide that back not only to our spoke sites, but to our telemedicine providers, so we can analyze how each physician is doing. For example, if one physician just takes a lot longer on the camera to decide to give thrombolytics, we analyze that information as well to work on self-improvement and quality control. So having that data is quite important, or else you're not going to know how you improve your care that you deliver. Sharing success, I would say, towards the end of the talk, just a few more slides. It's very, very important for us to understand as providers that the people on the other end, they don't, especially the ER, they don't really know what happens to these patients usually. Either they get admitted there and they lose track, or they get transferred. So providing feedback to our spokes, they get quite excited from that. So we oftentimes share success back to our spokes when in cases in which metrics are met or exceeded. So oftentimes I'll say, hey, boarding time was on 35 minutes. Great job, everyone. You did this well, you did that well, and they really take that with pride. So for the next patient, they're just going to be as efficient and if not better the next time around. Share good patient outcomes. Oftentimes the next day I'll call the ER back to let them know, hey, that patient that we transferred, they underwent thrombectomy and is doing well. And the ER doctors really feel excited about having that information. So highlighting that positive interaction, whether that's with the EMS, if they did a good job of bringing the patient quickly, or the nurses, if they understand that the Foley wasn't necessary, they focus on mixing the TPA. The ER physician, calling you because it was a mild stroke with some subtle symptoms, but it led to the administration and the patient did better, or even the unit secretaries that oftentimes are very, very helpful in populating the patient and stroke clinical apps that lead us to be able to do the consults more efficiently. It's important to, again, provide positive feedback to everybody that's fighting for the patient, not just the physicians that are involved. We do provide a lot of support for our local stroke coordinators and staff. They often reach out to us if the documentation needs to be better or edited. We participate on site surveys when the stroke center certification comes up. And, every year we also have an event in which all of our spoke sites get together and talk about, how things are going, how things network is doing, what are the directions, and they all learn from each other how they can do proven. They learn from it. It's very, very fun to hear them talk amongst themselves about how one site would do one thing and the other site can copy that, and how can it improve to better delivery of care. So I think one of the things that the successes that we wanted to show is that we do a lot of research in our network, and one of the most recent papers that were published by Dr. Kasi, one of our colleagues here, part of the UT telemedicine team, is that we did show that telemedicine can provide really, really great care despite the timing of the day or the day of the week. So there had been a lot of, there's been some research out there and studies in the past that showed that stroke outcomes were worse when presenting to the hospital overnight or on the weekend. So what we really wanted to look at was, how are our metrics and outcomes in our telemedicine network when we are on essentially 24/7, and we have the same doctors that are on during the day and nighttime, the same pool of physicians, so the care is very, really uniform. So we looked at our patients from September 2015 to December 2016, and we identified 424 patients that received IV TPA. 268 of those were after hours, 156 of them were on hours, and we looked at all of our TPA metrics, door camera time, camera to TPA decision time, administration time, and then we looked at 90-day outcomes. And what we found that no matter what day, the time of day or the day of the week, our TPA administration times are no different. Our complication times are no different, and our 90-day outcomes were the same, regardless of the timing. So what we were able to demonstrate that in our network, with the consistency in on our small, really lean staffing, the access to stroke expertise 24/7 via telemedicine can really ensure dependable and timely clinical care regardless of the time of day of the week. And I think that's very, very important. I think there's still some, not a lot, but there's still some reservation about telemedicine and telestroke, what it can do and strong limitations. But I would say that at least for acute teleneurology and telestroke in this specific paper, we are able to do a lot, and with a strong network, to try to get better, I think we're able to offer consistent. So with that, I'm going to kind of end. I think this is my last slide. I think it's really exciting for us in the telestroke world. Thankfully, Congress understood that and as well, that telestroke is very, very important in the role it plays. The community is there. And as of January 2019, telestroke is now being reimbursed by Medicare regardless of where the patient is. So we've started to do that at some of our spokes, and it's working out for us. It's not a lot of reimbursement, but any reimbursement is helpful, and hopefully that'll continue to grow into not just telestroke, but other teleneurology, telehealth services. So I would say, encourage your company or institution or network or to really dedicate somebody and really educating themselves and becoming an expert on telehealth reimbursement, because things are changing so fast, and you really don't want to be leaving resources on the table or reimbursements on the table in this scenario. Really there for the taking. So with that, I'll end. I just want to thank my team, Dr. Hagolino, Dr. Coffey, Dr. Zah, and Christy Ingram, our program manager. This is our core teleneurology team. That's really been a fun ride that I've had with them, and we're going to continue to grow and continue to learn. So thank you for that, and I'm happy to take your questions.
Thanks so much, Dr. Wu. Now we'll begin the question and answer portion of our webinar. Please make sure you get your questions in through the Q&A widget located on your console. So Dr. Wu, the first question that came in from Jefferson Fernand was, besides stroke and seizures, what are the most common other neurological disorders you're called for?
A lot of it is altered mental status, which is a very, very broad category, but I would say that it's just alteration of consciousness, probably the next thing.
Okay. Is the telestroke program financially sustainable? Is the financial stability of telestroke based on stroke volume?
Yeah, so I would say that's an important question. If it's financially sustainable, really depends on a few things. Specifically, if you're just solely living off of reimbursement that just went over, then it's absolutely not financially sustainable. And it depends on who you're working with as well. We have a fee-for-service contract, which means you're essentially giving us call pay to use, a different. I think people kind of understand the call pay. So you pay us X amount of dollars per month, and we will be on call for you and respond to all the calls that are necessary. There are other systems out there, providers that do a per-click type of consultative services. In my opinion, I think that's really sometimes disincentivizing the folks to call in that model. But again, some hospitals just really can't afford a lump sum per month. So from our network, it is financially sustainable for those contracts for us because we're really not. Our fees are not so high that they really are. We're not pricing ourselves out of the market, I guess. A lot of these facilities are actually paying local neurologists to take call that don't even see patients physically or providing the high level of care that we're doing. So it actually made sense for some of the hospitals to, instead of pay their neurologists, to actually pay us, and actually pay us less probably. So I would say from that standpoint, it is financially feasible. And then downstream revenue from your hospital standpoint, that's something we don't even measure, right? So if you bring a patient here and they get thrombectomy, and the hospital actually benefits from that. So does that feed back into your network and your telemedicine service to make it financially sustainable? Some places do that, and that's another way to view it.
Thank you. How many telestroke procedures are necessary or minimum for an institution to be proficient in this model?
Yeah, so I think it may be, as far as procedure, I think you mean consultations. How many consults should somebody see before they're proficient at this, at seeing somebody like this? Is that the question, I presume?
I think, yeah, so clinically proficient in the application of telemedicine for telestroke services, yep.
Yeah, I think that varies amongst the provider. I would say for telestroke specifically, it's not rocket science what we do. We're all neurologists. We've all seen patients. It's really understanding how to maneuver the technology, knowing the limitations and the strengths, and understanding how you need to communicate with our local nurses to help you guys examine the patients. Sometimes our fellows are very, very proficient, and they learn after 10, 20 consults, and sometimes it takes longer. So I think it's very different for everyone, but at least from our standpoint, we're able to monitor and observe and check off on who's proficient or not. There is no formal way of evaluating at this moment, so it's not like somebody has to be boarded in telestroke to do that. So oftentimes I'll see physicians that are very, very inefficient and not able to do it in a fast manner. That may be because they never really were taught how to do it correctly or or understand how to improve. Nobody really monitored them or observed them and gave them feedback.
Thank you. What is the format of interview or assessment for acute stroke on telestroke? Does the teleneurologist wait to be called or paged, or is telestroke on and live as soon as the patient arrives?
Yeah, so what we do is, the format of interview and assessment for acute. You guys took that off already. We actually get paged, and as we page, we get a very brief update with the ER doctor or the triage nurse about what we're getting into. Oftentimes, it's important to understand kind of the environment in which you are when you log on, before you log on, kind of the situation you're dealing with. We are encouraging and have always encouraged our spoke sites to call us before the patient gets their CAT scan or labs. We're not expected to get on the camera, have everything done. Then you're never going to meet your neonatal times. So what I like to do is get on the cameras as soon as I understand that this is a potential acute teleneurology case. If the patient's in the CAT scan, that's great. Let me talk to the family, go to the EMS. I can gather as much information as possible from them, and as the patient gets back, I'm looking at the CAT scan, examining quickly to understand whether they're a TPA candidate or not, if they're a thrombectomy candidate. So that's how we've operated. We're not always going to be on. We're so busy now, and I would say most sites are so busy, you're not going to be able to just log on and just wait for the patient. That's just not efficient for you, and it's not efficient for them, because for the most part, some of these patients sometimes don't even need to be seen on the camera. If you get on the camera, you're waiting for them for 30 minutes, and you realize that's something 3 weeks ago. That's really, you don't really need to be involved in that case to provide that. Because
Okay, thank you, Dr. Wu. Is your organization accredited with a telemedicine accrediting body, and if so, which one?
So we're not accredited with any telemedicine accrediting body.
You mentioned the educational component, but the question is, do you have any educational component for the providers and staff at the spoke hospitals?
Yeah, so the educational component that we provide here, do you have an educational component for providers and the staff? Yes, so we provide, education regarding IV TPA administration, metrics, the importance of, and, what does thrombectomy offer. We would provide that to the local nurses, the ER team, at the spokes hospital. So we do teaching at our local spokes, because it's quite important for them to understand kind of why we're doing things. They don't kind of understand the ramifications of why they need to do the CTA in the first place and why they need to do it fast. Well, if they understand we need to identify whether the patient has large vessel occlusion and, treatment is dependent on time, then the next time when they get that patient, they're going to really figure out that, or at least get that executed in an appropriate, timely fashion. So we do, educate them, but there is no formal syllabus that we go through for our spoke hospitals necessarily.
Thank you. I wanted to put in one of my own questions here. So your team is relatively small, and yet it has some of the most active teleneurologists anywhere in the world. Can you share, really, how did you achieve that?
So I'm going to say, I don't know how I achieved it. I think we just have a very, very dedicated team. I think teleneurology, and this is probably one of the hardest things that we've had problems with, is attracting other people to participate in our network, or not participate, or, recruit, I guess. Working in an academic setting and taking teleneurology as your career is a relatively new thing. And not many people understand what we do unless you really grew up in our system. So, I was trained here. All of our other attendings have trained here in the past, because it was really difficult for other people that train at other programs to understand that you can do this as your full-time job. So I think because we have a small team and we have the same goals and we understand that this is our program, that makes it a lot easier for us to be more efficient and learn. We're not doing other things while we're on teleneurology. This is our 100% focus. So I think that helps us. A lot of programs that expect their teleneurologist to be on call for the hospital and teleneurology and rounds at the same time, because they don't understand that in order to be successful and efficient, you really need to be dedicated to this, and they think this is just an add-on. That sometimes can lead to the failures of successful program.
Thank you. What are the clinical components of stroke assessment on telemedicine?
So the clinical components, we obviously do an internet stroke scale. We do a quick, basic neurological examination. The ER doctors are there to provide general examinations as far as, the ABCs. We look at the vitals. We look at the labs if necessary. We look at the CAT scan. It's very, very straightforward. I think that's why stroke has thrived in telemedicine, because you're able to make decisions fairly quickly using this using telemedicine.
Thank you. Would you be willing to see patients in other states, or do you keep it local?
So that's really dependent on what your goals are of the program. There are commercial providers out there that see patients throughout the United States. So we decided to keep it very, very local. We do have one hospital in Midland, Texas. That's about 4 or 5 hours from us now that we don't take patients to, but we have another facility in which we've have a very good relationship in which we transfer patients to. But we felt like for us, we were able to provide the higher quality of care when we're keeping it local. Willing to see patients, a lot of that relies on credentialing and licensing. You really need to be licensed in all these other states. And for us, in an academic institution, it really doesn't make sense for us, because we're not in it for financial stability in a sense of needing to attract that. We have enough business that we really can't handle it even locally.
Thank you. We're just going to have time for a couple more questions. What clinical and financial metrics do you look at when determining a new potential spoke site?
So when we're determining the spoke site, I'm not really looking at their clinical metrics. It's more of, do you need our services? Obviously, is important. So do you have enough of a volume to even sustain a network needing our services? That's important. And what are they looking for? Financial metrics, I really don't have any. Our payment or our fee structure is dependent on volume. So, it may vary. If you're very, very busy, you pay a little bit more. If you're not busy, you pay a little bit less. But it doesn't even make sense for you to spend money on technology if you don't have the volume. Because sometimes people think they need telemedicine when they really don't. So that may be not something that it's not that important from my standpoint as far as there's no metric necessarily.
Okay, thank you. Sort of a building on that question. So on how is the technology or sort of teleneurology service funded? Are all of your spoke sites in geographic areas eligible for telemedicine reimbursement, or do some spoke sites fall within metropolitan statistical areas / urban areas?
Okay, so when you're talking about teleneurology, Ms. Leanne, our teleneurology service is funded. I think you're meaning general neurology or routine consultative services. Those are also funded by contracts. So facilities pay X amount either per consult or per month, and we just do our consults that way. And we do not bill for teleneurology, routine teleneurology service, because, again, to fall under the geographic areas that's been designated by Medicare, it's almost like never impossible to sustain a network that way. So we do not bill for general teleneurology. Now, for acute telestroke, like I said before, you're able to bill regardless of geographic areas. So
great. Thank you. Oh, sorry, go ahead. Thank you so much, Dr. Wu. Scott?
All right, well, we'd like to give a big thank you to Dr. Wu for today's presentation. For the questions that were not answered, we will be able to follow up with you via email. And for any additional questions or information, you can please feel free to contact us at feedback@intouchhealth.com or visit our website for a list of to find this recording or for upcoming webinars. Thank you, everybody, for joining us.
Hey, Scott. Sorry.
Yeah.
Hello? Can you, will you be able to give I guess there's a lot of questions that I didn't answer. I don't want to not answer them. So will you be able to email me these and I can email these specific people back or just give you the answers?
Yes, that is the plan.
Right.
Thanks so much, Dr. Wu.
Thanks. All right.
Thank you, everybody.
Thanks so much.
Thank
Bye-bye.
you. Bye-bye.